Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare and moderator for today's program. The program will begin with a presentation and we will have a question and answer session after the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they have during the time we have, and will follow up on questions they did not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Tim Darling has led the Objective Health product development team since 2010. This team is responsible for building the platform of tools and analytics that power Objective Health products and client service teams. Tim is passionate about leveraging large data and cutting-edge analytics to bring strategic and financial insights to U.S. hospitals and systems. Prior to joining McKinsey, Tim led the development of enterprise web applications at the University of Maryland. Ben Riegel is a knowledge expert for Objective Health. He joined McKinsey in 2011 and leads the strategy, purchasing, and revenue cycle initiatives for Objective Health in North America. Benjamin is responsible for the development and delivery of these programs to Objective Health clients. His most recent experience includes leading hospital system engagements with a revenue cycle consulting firm and holding multiple leadership roles at Borges Medical Center. Sapan Anand is currently a product manager with Objective Health. He joined McKinsey in 2009 and works on the strategy solutions. Prior to McKinsey, he worked for Epic Systems Corporation, one of the leading EMR vendors, for 7 years and led several EMR implementations with hospitals and academic medical centers across the nation. It is now my pleasure to turn the floor over to Tim Darling to begin today's presentation.
Thank you. The topic of this afternoon's discussion are your cost estimates leading you to the wrong decisions and what to do about it. We'll have 3 parts. Next page, please. First, and quickly, we'll talk about the fact that most hospitals today use cost-to-charge ratios as estimates for their patient cost and accounting systems. Then we'll talk about how cost-to-charge ratios can lead to suboptimal decisions, both strategic and operational ones. And finally, we'll talk about some of our experiences serving clients who don't have detailed activity-based costing and how we've managed to overcome some of those the shortcomings of the cost-to-charge ratio system. The takeaway from the discussion really is simply that increased accuracy and costs are more vitally important now than ever. While activity-based costing is the best solution, you don't need to invest in an expensive cost accounting system. And we'll talk about some of the approaches that we've discovered. Next page, please. So this is a series of quotes from a Harvard Business Review and New York Times article by Robert Kaplan and Michael Porter. Michael Porter, of course, a leading strategic thinker, author of many foundational books on the topic of strategy. And he and his colleague in these recent articles addressed the importance and the current state of cost estimation in hospitals. I'll read the standout quotes here in bold. There's almost a complete lack of understanding how much it costs to deliver patient care because providers themselves do not measure their costs correctly. They assign cost to patients based on what they charge. In other words, cost-to-charge ratio. And then the article goes on to talk about some of the more macro consequences of this and building up actually to the fact that the total growth in healthcare costs nationwide in some way can be attributed to this problem, although in this particular discussion we'll talk more specifically about implications to hospitals themselves, hospitals individually in their own decisions. Next page, please. So we'd like to start off with a poll. And the question is, what percentage of U.S. hospitals use cost-to-charge ratios as the primary form of cost estimation in their patient data? And we'll give about 60 seconds for this question. Any of the attendees, I believe, can use buttons on their screen to vote. Okay, another 30 seconds or so. Okay, let's close the poll there. There's about a minute. 45% of the respondents voted 70 to 80%, 34%, 50 to 60%. In other words, the overwhelming majority of the attendees believe it's at least 50% of hospitals that are using cost-to-charge ratios, and certainly a strong leaning towards that. The vast majority do not. Next page, please. So the audience was correct on this one. While exact numbers do not exist, based on a couple of recent articles, we believe that about 50 to 60% of hospitals use cost-to-charge ratios. Having said that, 20 to 40% use some other form of cost accounting, which we actually don't know what they are and how good they are. They may, in fact, be subtle improvements on cost-to-charge ratios. And about 10 to 20% use pure activity-based costing. These numbers roughly reflect our own client experience. They also reflect an interesting insight that we've had from our own client experience, that even hospitals that claim to use some form of cost accounting actually still have a number of areas that they can improve. They're often hospitals in these sort of other cost accounting type buckets. We'll talk about them and some of those opportunities to improve as well. Just to level set for the discussion, activity-based costing is an approach that measures activity associated with the patient care and associates the indirect costs of those activities to the patients. In other words, the amount of nursing time spent with the patient would be measured, and the cost of that nursing will be attributed directly to that patient. The other types of cost accounting vary greatly in accuracy. And in fact, over 100 to 200 hospitals that we've looked at, we've never seen drug and implant costs really accounted for accurately in sort of these either cost-to-charge ratio or other cost accounting type systems. And that is actually the big focus of today's presentation. So next, please. So we'll go to the second section here on really the burning platform for this. So why does it matter? Well, what are the implications of cost-to-charge ratios? And we believe this is new research, frankly fascinating research, and sharing it here for the first time. So next page, please. So later in the discussion, we'll look at the impact of cost-to-charge ratios on hundreds of hospitals. We'll take a real bird's eye view and really talk about this as a landscape issue. But to start, we wanted to focus on a single hospital. It's a real hospital. We'll call it Valley Hospital. It'll make the analyses that we talk about later a little bit easier to engage with when you sort of have an anecdotal some data point in mind. This is a 250-bed hospital, rural setting, and they actually do have a form of cost accounting. And what we're going to do is look at their data with their actual cost and compare it to what their data would have looked like if they were using cost-to-charge ratios, and ask ourselves, would they have made the same decisions? Would they have the same insights about their own data? Next page, please. So let's start with drugs. Well, actually, a majority of this presentation will actually be focused on drugs. But we, and here we see 10 top drugs for Valley Hospital. Down the left side of the page, the name of the drugs, and the gray bars in the bar chart are the actual cost of those drugs per dose. The blue line, the blue sort of tick marks, are the estimate of the cost of those drugs when using cost-to-charge ratio. So you can see there's some drugs which are pretty good and some drugs where cost-to-charge ratios are quite different. Let's start with the second one down from the top, pip/tazo. This is a drug that by their own purchasing data costs about $20 for this particular 3.3 gram dose. Cost-to-charge ratios overestimate that by about 100%. And peg it at $45. Compare that to the second one from the bottom. This is 10 milliliters of insulin. The actual cost of that drug being $65, but cost-to-charge ratio is estimating it at $15. In other words, you have pip/tazo vastly overestimated by cost-to-charge ratio, insulin vastly underestimated. So one thing that we've heard from hospital executives is that it really doesn't matter that my drug costs when using cost-to-charge ratios don't match my actual cost, whether they're 2x or 3x what they should be. As long as all drugs are overestimated, then what matters is the relative difference between the drugs. And so what we see on this page, for one hospital, and for some drugs, we at least see that there are some drugs that are overestimated and some drugs that are underestimated. That's going to be sort of the precursor for some of the decision-making problems that we'll start to see in the coming pages. In fact, I don't want to harp on this too much, but mathematically, it sort of has to be that some drugs are overestimated and some are underestimated. Cost-to-charge ratios take, the cost-to-charge ratio for drugs accounts for the total cost in your hospital. I mean, if you add up if you take all your drugs using cost-to-charge ratios, you add them all up, you'll actually get the total cost of drugs for your hospital. So the net result has to square, and so if some drugs are overestimated, others have to be underestimated, and that's exactly what we see here. The next page, please. Now, I'm going to, here on this page, we'll look at the top 200 drugs of value. So in other words, still just one hospital. Let's zoom out and look at 200 drugs. Now, not just 10, but 200 drugs. This is a chart type that we're going to come back to a few times. So I'm going to take a moment to explain it. On the x-axis is the actual cost per dose of the drug. The y-axis is your estimate using cost-to-charge ratios. And then this is a bubble chart, and the size of the bubble represents this particular hospital's total spend on that drug. So, in other words, enoxaparin, which you see is the biggest bubble there in the center, is overestimated by cost-to-charge ratio. In other words, it's about $25 for this 40 milligram dose, and the cost-to-charge ratio is pegging it at around 45, so overestimating that particular drug. And it's a very big spend item. And then, interestingly, towards the very bottom left, and you can't quite see it on this page in a lot of detail, but you can get the sense for it that most of the very low-cost drugs, like Tylenol, are actually underestimated by cost-to-charge ratio. There's a bit of a pattern to this page for this particular hospital. This is a bit of a pattern that the low-cost drugs, your dosage of Tylenol, are underestimated by cost-to-charge ratio. Your more expensive drugs, per dose, tend to be overestimated. So this is a nice view that. Actually, no, at least for Valley Hospital, this is not a problem just in 10 drugs. This is a problem across their entire portfolio or their entire formulary. Now let's look at the next page. Now here, we're going to take a slightly different view. So we're going to look at two physicians with one DRG, septicemia. So on the previous page, we saw that some drugs are overestimated, some drugs are underestimated, and now we see the implication of that. We're starting to get towards the, what are the types of decisions that might be impacted or adversely affected by cost-to-charge ratio. So on the left side of the page, you see Dr. Chan. He uses a set of drugs on average across his septicemia patients that are overestimated by cost-to-charge ratios for the most part, right? You can see this the bubbles of spend. There's above the line there, above the line. And then Dr. Monroe on the right-hand side of the page, heavy user of linozolid for his cases. Linozolid is a drug that is in this particular hospital severely underestimated by cost-to-charge ratio, and so you're beginning to sense what this might mean as we start to talk about reduction of clinical variation within a DRG across our physicians. So in fact, we do see that on the next page. So Dr. Chan at the top of the page, same chart as on the left side, the same two charts that we just saw. Dr. Chan now is on the top of the page. Using the cost-to-charge ratio approach, looks expensive. He looks like $1,290 per case, drug spent per septicemia case, because all of his drugs are overestimated. Well, Dr. Monroe looks cheap. So you would actually say if you were using some product that does clinical variation analysis, there are a number of products in the market. Objective Health has a product that we serve our clients with. We'd actually say, within septicemia, what type of opportunity might I have if I normalize the utilization of drugs to, say, my lowest cost physician, or accounting for quality, but to my lowest cost physician. In this case, if you're building that analysis on top of cost-to-charge ratios, you would come to the wrong conclusion. You would say, Dr. Chan, I'm going to need you to look more like Dr. Monroe. Now remember, the names are de-identified. This is a real hospital, real data, real DRG. As you see with actual costs, it turns out that Dr. Monroe is much more expensive than we thought with his heavy linozolid usage. And in fact, if we were to make that decision, if we were to actually go to Dr. Chan and try to have that conversation with him, we thought we would be saving $10,000 a year or more, given the case volume of Dr. Chan. Turns out we would actually be making a very suboptimal decision here, and would be losing $6,500 a year. So really this is, you might say, all right, this is just one hospital, one DRG. Maybe it's real data, but you've sort of chosen it. You're presenting what it's a view of the world that it reflects what you want to say. We'll come to that in a second. But I think, at least for this particular hospital, for this DRG, I think we can safely say that if you're building, if you're sort of deploying clinical variation reduction analyses on top of of these cost-to-charge estimate costs, you're basically building a castle on sand. It's worth pausing here for a second, because that's a critical insight. For this type of analysis, cost-to-charge ratios are dangerous. They may work in some cases, but clearly we've proven that there are cases where they can be dangerous. So at least for this hospital and for this particular DRG, we can see a good example of that. So next page, please. And here I'd like to do sort of our second poll, second of two polls. And again, we'll give you 60 seconds. And the question here is, if we look across the top 20 DRGs in an average hospital, so in other words, we have a cohort of 100, 200 hospitals that we can actually step back and look at. But just looking at the top 20 DRGs for any given average hospital, what % will look like this case that we just saw, this Dr. Chan, Dr. Monroe type of case? In other words, sort of in a quick sentence, how common is this type of discrepancy between cost-to-charge ratios and actual costs? We'll give 60 seconds total for this question. And about 30 seconds left. Okay, well, why don't we stop the poll here? It looks like about 45% of the respondents said 50 to 60%, followed by 20 to 30%, which were on the other entries there. So on the next page, the audience was largely right by our estimation, although perhaps slightly overestimating how common this is. But still, it is we estimated about 35%. That's looking over 100 hospitals that have cost accounting, and just saying the top 20 DRGs. We asked if they were to be using cost-to-charge ratios, would the physician that they thought was the lowest cost really be the lowest cost? About 35% of the time, the answer is no. So it is indeed a common problem. And just as a footnote to this is only looking at DRGs that have at least 2 physicians, and each physician has at least 5 cases. Again, looking over 100 hospitals. So so indeed, this is I think this sort of makes the case for change, at least within the world of drugs, that this is an important and critical topic. And as we mentioned at the top of the discussion, hospitals are increasingly looking to their data, their cost data, their patients' data, to answer these nuanced questions around reducing variation and a number of other things. And so increasingly, as they look to their data to answer these questions, increasingly it becomes critical that we take a sharp, keen eye to the quality of the data that's supporting those analyses. Next page, please. Now this page is fascinating, frankly. So now we're going to zoom out again. So we've been looking at Valley Hospital for a while. Let's zoom out. And you may remember how we looked at Valley Hospital's top 200 drugs and found that, for the most part, cost-to-charge ratios were overestimating the high cost for those drugs and underestimating the low cost of the low-cost drugs. Right? So they were. And we thought it was kind of interesting for Valley Hospital, but it was just one hospital. Well, actually now when we zoom out over 200 hospitals, and we look at, for example, in Enoch-Perrin, over 200 hospitals that have cost accounting, we basically see the same story. That interestingly, it's a little more a nuanced story. That, for the most part, over 200 hospitals, drugs average closer to the to the green bar, where we sort of would hope they would all end up. Where cost-to-charge ratios are accurate, but there's still a bit of that story that the low-cost drugs huddle towards the bottom, tend to be below the green bar, and then higher-cost drugs above it. And the point really here is that Valley Hospital is representative. It is like most hospitals, and this is again, this is a systemic issue. I'm actually not necessarily sure what to do with the output of this page, but it is frankly, this is a fascinating insight to how cost-to-charge ratios work across many hospitals. So we're going to switch to the next page, please. So up to now we've talked about drugs, which is a very granular, specific view of hospital costs. So here we zoom out again and say we're still within Valley Hospital, but now we're going to look at Valley Hospital's costs at a service line level. So if you look at their Valley Hospital's top 10 service lines, and we rank order those service lines by total profitability, what we discover is that, for the most part, cost-to-charge ratios mostly okay. Pulmonary medicine is the largest contributor profitability either way, whether you use actual cost or cost-to-charge ratios. Cardiovascular medicine comes in second, etc. So what we would say is that, you start to see the story that historically hospitals have largely looked at their patient data, their cost estimate data, to answer very high-level questions. Rank ordering of service line profitability is a very high, one of the most highest sort of questions you could ask of data. And for that part, cost-to-charge ratios have held up. There's some exceptions, but they hold up. As we've seen, this hospital increasingly looked at ask more nuanced questions from their data. Cost-to-charge ratios do not reflect this level of accuracy. But even here, even at the service line level, we do see something interesting with orthopedic surgery. And this is one example of a top service line where cost-to-charge ratios aren't very good in our experience in estimating cost and therefore profitability. And this is an area, as highlighted here, we'd like to have a little bit more of a detailed discussion on. So for that, I'm going to turn over to my colleague, Ben Riegel.
Thanks, Tim. So part of my role at Objective Health is to lead engagements around supply chain. And so we worked with Valley Hospital, in specific, orthopedic surgery implants. So a lot of surgery people on the line today. And so you're intimately familiar with hip and knee implants. And we were doing kind of a classic look at demand matching and pricing. and really found some savings for Valley Hospital. But of course, what we ran into was pushback from surgeons, and kind of your classic pushback in saying, we're a very profitable service line. We've been the most profitable, and so really didn't feel like they didn't have the kind of burning platform to change. And so we went back to the drawing board and we really dug in, and we said, okay, well, let's look to see what are we, what kind of profit are we actually making from these procedures? Let's start to really dig into it. And so what we did was we dug in and we found. And so if you can go to the next slide, I'll show you what the results for hips are. So they had done this analysis, and using their kind of cost to charge methodology, they came up with around 37% contribution margin, which is pretty good. Not great, but it's pretty good. And we've broken it out. On the left-hand side, you can see the revenue, implant cost, variable cost is VC. There are other variable costs associated with those cases. And if you take off the fixed cost, get to a profit margin around 670. Now, interestingly, if you really look at what the actual, what is actually costing them in implants, it's right around $7,200. It's almost a $3,000 difference, and that's significant. Obviously, I don't have to say that to anybody on the phone. I think that's really significant because it changes their outlook significantly. And now they have a 17% contribution margin, and they have a negative profit margin if you take in fixed costs. If you go to the next slide for me. Knees is a similar story, not as significant. As you can see, about $1,300 difference and underestimating the actual costs. But again, dropping their contribution margin pretty significantly. So you can see when you start taking these, when we really started to dig in and we found what actually is happening, and we took this to their senior leadership team, it was significant. For years they thought they were making a lot of money, especially on hips. And what we had to tell them was basically that their implant costs they've been underestimating, specifically in the approach that they've been taking. And this was a huge point, and it also created the burning platform, which was significant because for years they had, as I said, they've been just assuming they're building on a program that they thought that was really kind of really taking them to another level. So with that, I'm going to turn it back over. That's what happened at Valley Hospital with implants. It's a real case study for you.
Thank you, Ben. Next page, please. So we're getting towards this is the end of the analytics section here of the presentation. And we've looked at drugs in great detail. We've looked at drugs for Valley Hospital. We've looked at drugs for 200 hospitals. We've looked at implants for Valley Hospital. We've looked at service line, profitability for Valley Hospital. So we've taken a few different views of, of different lenses, for some very specific, some wider angle. This is this in the next page are the widest angle lens view of all of them. And so, here we sort of zoom out all the way and look at the cost per case for cardiovascular cath inpatient procedures as a service line across 100 hospitals. And this is a fascinating insight, frankly, that for almost all the 100 hospitals that we post here who have cost accounting, when we look at their actual cost per case on the x-axis and compare it to what their cost to charge ratio would have been, across all categories, drugs, implants, room board, the whole, the total cost per case, you actually find the cost to charge ratios across almost all hospitals overestimate the cost. And so this page is telling us that for most hospitals in the United States who use cost to charge ratios, guess what? Cardiovascular cath is probably more profitable than you believe it is. For your hospital, cardiovascular cath is more profitable than you probably believe it is. I mean, it's, there's a call out on the page, trying to give some numbers. A particular hospital there would overestimate the cost of their cardiovascular cath by 15%. That's a bit more of an extreme one. It definitely looks like, on average, in the 5 to 10% range. But just a, we often hear from clients as well that charges are very random. There's not much pattern to charges, to cost-to-charge ratios across hospitals. That may well be true at a certain view, but when you really zoom out, you actually do see this pattern. It may be that hospitals typically overestimate the stent implants, or perhaps they overestimate some of the higher cost drugs that are used here, sort of we've seen on previous pages. There are patterns that appear across multiple hospitals. Next page, please. On the other hand, when we look at orthopedic surgery, as Ben had discussed, most hospitals underestimate their cost per case. So when you see, what you see here is from these analyses, is that hospitals are much more similar than they are different, interestingly. And again, I think probably across most hospitals, the underestimation of cost-to-charge ratio, the underestimation of the cost per case, may well be due to implants, as in Ben's example, that is actually systemic. This is not, we show the anecdote of Valley Hospital to kind of make the case, give the data point for us to discuss. But there's a lot, the hospitals are more similar than they are different. And the impact of this really is that across most hospitals that have cost-to-charge ratios, it really does impact the view of the profitability of their service lines. Most hospitals look like Valley Hospital. Most hospitals probably believe their orthopedic surgery is more profitable than it actually is. So that ends this section of analyses. Next page, please. And I'd just like to recap here sort of what we've talked about and the implications of it. So we started by talking about most hospitals use cost-to-charge ratios to estimate their patient costs. And we've also said that even those with some form of cost accounting, the vast majority don't really account for drugs and implant costs accurately. We've looked at hospitals that use cost estimation to prioritize their service lines and DRGs for growth. And then we saw examples of this and believe that cost-to-charge ratios are roughly okay when prioritizing and rank ordering service lines. But but for any given service line, there can be quite a difference between cost-to-charge ratio and real cost in terms of how you might view the real profitability of your service line. And increasingly, hospitals are looking now at their data for more detailed insights. So who is the lowest cost physician for a given DRG? And what is the driver of that low cost? They are looking at their data to ask questions about how do you become more competitive in a world of increased cost and price transparency. How do we prepare and navigate in a world of population health? And here, these are much more nuanced questions that really require much more accurate costs. That Michael Porter and Robert Kaplan were talking about at the top of the discussion. The real need for those accurate costing. Cost-to-charge ratios are just not suitable, and an improved approach is a fundamental need. That the cost-to-charge ratios here lead to inaccurate insights and often the wrong strategic and operational decisions. And we only have an hour for this webinar, which is a relatively short time to sort of cover the richness of this material. I know we've shown a lot of analyses up to now. We've presented a few charts. We might have gone through some of them a bit more quickly than we would have liked given the time constraints. But we're happy to discuss the analyses more during the Q&A session and after the session as well. So next page, please. And so that brings us here to the third and final section. So to round out the hour here, we'd like to share now some insights into how we at Objective Health have helped our clients overcome some of the challenges that we've talked about, and how, as well, if you're a hospital wants to implement and overcome these challenges yourself, some pointers on how you might be able to do that. And for that section, I'm going to turn over to my colleague, Sapananath.
Thank you, Tim. So now that we have seen some examples of how cost-to-charge ratios can lead to inaccurate costs and hence wrong strategic decisions, Let us look at what we can do today, even if we do not have full-fledged and sophisticated activity-based costing in-house. The good news is that there are data sources already inside the walls of the organization that contain information about actual costs that most hospitals can utilize more often than they do today, and more effectively for better cost estimation. So let us take the example of drugs to illustrate that. Next slide, please. So, one of the key things that we have observed in many clients is that there is a disconnect between two data sets which contain information about costs. On the one hand, there is the detailed patient encounter and charge files, which contain a log of all patient encounters occurred, all charges placed in any given time frame, including drug charges, in addition to all other categories such as supplies, room and board, lab, and so on and so forth, and also the estimated costs. And this information forms the basis of all kinds of analytics performed to aid strategic decision making. On the other hand, there are the purchasing files which contain logs of all purchases, including costs, quantity, charge descriptions, etc. One of the main reasons that these data sources are not married and are often underutilized today is the complexity involved in joining these together, which is in today's world not as seamless as we would like it to be. Next slide, please. But if we imagine a world where there is a seamless information flow between these sources, we can see that now your existing patient encounter and detailed charge files, which are the basis of all the analysis, are much, much more powerful, in a sense supercharged by better insights into costs at an equal granular level. In addition to connecting these data sources, one of the things we also provide our clients are benchmarks that could also be used in conjunction, which are created from a data set of hospitals which have actually implemented activity-based costing and is refreshed every quarter to reflect the latest pricing. But even if the hospitals, even if your hospital does not have any benchmark sources, it is still extremely valuable to use the data that is already available in-house. So let us look at an illustrative example of how we could go about bridging this disconnect. Next slide, please. So let's take an example of drugs. In the case of drugs, the very first task is to be able to categorize any drug charge from any data source into a common language, which is now consistent across disparate data sets, so that now you can do an apples-to-apples comparison across different sources. Some of the challenges that we have seen with this process is that it can be extremely manual and time-consuming and hard to maintain. One of the major reasons for this being the fact that oftentimes drugs are specified in different but adjacent forms. So as an example, if we look at the first two drugs, which are both versions of enoxaparin, but different, specified in different ways. One is, in this example, one is taken from the purchasing log and one from the detailed charge file. By looking at this, you can tell that it makes it difficult to just combine these two data sources. But when we categorize them, we can see that they are really the same dosage, routes of administration, class, generic name, etc. And given that we are in a dynamic world where charge descriptions keep changing, costs keep changing, it can be hard to keep up. Similarly, there are some more examples of these with different dosage patterns and different versions of drugs. But to summarize, the point here being, even if the hospitals do not have sophisticated activity-based costing today, they can still embark on making targeted improvements with the information they already have in-house and take the next steps. With that, I would like to open up for Q&A.
Thank you. And next slide, please.
Okay. Great. Thank you all for a very informative and enjoyable presentation. We're going to start the Q&A portion of the program now, and as a reminder, you can submit any questions you have by typing them into your control panel in a space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and will follow up on questions they do not have the opportunity to address. Okay, the first question I have here for you is, can you shed some light on the functionality and level of sophistication of the tools needed to do drug cost estimation For example, what are some complexities they need to be able to handle in order to provide accurate results?
Sure. This is Sapan. I can take this one. So the main functionality that you would need is to take any drug description and be able to classify into multiple categories that are both detailed and granular enough so that you can use this information in multiple kinds of analysis. The complexity that we have seen in doing such a task is around creating a general purpose tool that can do things like sophisticated pattern matching using technical things like regular expressions and building in logic for handling a hierarchy for more specific to least specific patterns, handling multiple keywords and drug names, and being able to do calculations in an intelligent way and in multiple ways so that you end up with the right categorization for each of those things like dosage information, routes of administration, generic drug names, things like that. So really the challenge is to create a tool that is sophisticated but not overly complex to maintain and something which is extensible and can be widely used on a variety of data sets. So something that is generic enough but can still handle enough special cases for it to be worthwhile.
Okay, great, thank you. Next question. If hospitals on average overestimate high-dollar drugs and underestimate low-dollar drugs, can't hospitals just adjust for that instead of a more sophisticated fix?
Yeah, hi, Tim here. There is actually, when you step back and look at the implication of cost-to-charge ratios across the expanse of a hospital, there are obviously a number of cost centers that you have to account for. There's the costs of a patient build up from room and board costs, implant costs, drug costs, procedure costs, operating room time, emergency department, and so on. And so the truth is, for the most part, there are no quick and easy fixes to individual elements of cost estimation. However, in the drugs world, we actually believe there is a legitimate opportunity to inject, as well as implants, but drugs as well, a legitimate opportunity to inject the most accurate data that is available into the cost estimation of a given patient. And this is a tremendously critical opportunity. People often look to drugs and implants and other high-spend areas for some of their cost reduction efforts. So I think there may be an opportunity in some of the other areas. So if you might say the general rule of thumb of people, maybe I'm overestimating orthopedic surgery. There are some, maybe those rule of thumb as you go and a given hospital looks at their own cost estimations, their own estimations of profitability. Perhaps those could be useful as a first pass. Yes, there probably are some at least high-level takeaways from this presentation that maybe you look at with a new set of critical eyes to your own data if you've been using cost-to-charge ratios. I actually think in particular, the opportunity to really do the most granular and accurate work we can in the area of drugs is just, as well as implants, is just so compelling. From our point of view, though.
Okay, thank you. We have a question here from an attendee who says, RCC versus actual cost seems to pose a dilemma for hospitals. Just as implementing EHR, cost accounting can be expensive too. What will you suggest as a cost-effective way, especially for small and mid-hospitals?
Well, I can take a quick swing at it. I mean, indeed, we didn't want this presentation to be about the dangers of cost-to-charge ratios, and then the last page be, by the way, there's really nothing that small and medium-sized hospitals can do, and other than implement multi-million-dollar systems. That was, that's certainly, not the message we wanted to convey. We've talked about some particular opportunities that hospitals can take. So there's some specific granular thoughts here about, as Safan had mentioned, connecting disparate files from across the organization. That can be done with a sophisticated tool, but it potentially could also be done by an analyst within a hospital that has some knowledge of the different files and the entries within those files, that could work as well. It would take a bit of work. In our experience, it takes a bit of work. But you could, step back. Well, we hope really that this presentation is less about sort of specific tactical, concerns and tactical, potential updates, and more just about creating a very critical eye to sort of some of the, the implications of the estimates that are being used today. And I think from those types of, from just taking that critical eye, in our experience, we've had very productive conversations with the hospitals individually, and there isn't a one-size-fits-all answer to that. But as Ben talked about the experience at Valley Hospital with having the discussion with their physicians with their implants, that was a that was work that Ben and his team led while serving that hospital, and it's certainly that type of work. You don't need sophisticated cost accounting, expensive multi-million-dollar cost accounting tools to do. Just asking the right questions, having the resources to poke around, and stimulating the right conversations with the physician leadership in the hospital is I think should be goal number one for any small to medium-sized hospital.
I think just to add to that, also focusing on where the money is. So within drugs, focusing on the top few drugs which constitute for the majority of the costs. Within implants, focusing on the top few implants that constitute for the majority of costs would also help bring down the size of the problem.
Yeah, I would echo that. I used to work in surgery, and I would say focusing on your big ticket items can get you halfway there, or focusing on, in our case, we focus on hips and knees. I mean, you can focus on spine and get down to bigger ticket items and really get a real sense of true cost, true profitability. I think that's what I would start with.
Okay, thank you. This question, Porter and Kaplan have talked about the value of including physical space utilization into account as part of the cost of a patient encounter. Do you find that a valid and useful premise?
Yeah, that's right. That's a good question. It is absolutely it is. So when you talk about real activity-based costing, what you want to do is for any given patient, as much as possible, calculate the materials, the nursing time, the other resources that are used in the service of that individual patient. And one way to do it is to the hospitals do it is to use relative value units of a given patient. You might identify that there's a certain amount of nursing time or other resources that were used during the patient's stay that could be documented using a system like that. For example, for its physical space utilization, you specifically might consider private rooms versus semi-private rooms versus wards. In our experience, our clients do account for those separately. They do have their own set of charges, if you will, associated with those type of room and board space utilization. And we have not thoroughly yet researched the implications of cost-to-charge ratios on that particular area, but it's certainly one of the, as Ben says, you focus on the areas of big spend. That is certainly one of the next ones that we're going to be looking at for our own research, and and also with our clients.
Okay, thank you. I just wanted to direct the attendees' attention to the last slide. If you have additional questions, you will find the email addresses for all three presenters, as well as to remind you, if you do have a question for staff, you may enter it into your control panel and click send. I do have a question here. How do you get your physicians to understand the cost to charge methods and its problems? Hello?
I can take a crack at that. That one is probably best for Ben. It's relationships with physicians and discussions with physicians are sort of the cornerstone of executing on any good idea. That a lot of people have a lot of good ideas. There's a lot of good analytics out there, and communicating to physicians, having candid discussions with physicians, giving the physicians the data that they need, listening to their feedback and concerns are sort of obviously the critical linchpin in making sure that we go from good ideas and interesting analytics to impact. And I think in terms of our experience working with physicians, I don't know that perhaps physician leaders, executive physician leaders might be aware of the idea of cost to charge ratios. They might have anchored on specific ideas about the pros and cons of it. I think for the most part, physicians are somewhat, in a sense, agnostic of cost accounting systems, cost estimation methodologies. And what you can, I think the slide that Ben showed earlier, where you just sit down and say, listen, I don't know how much you've seen of this before, physician, but historically, when the leadership or financial team have looked at profitability across our service lines, across our cases, what we've been looking at has been the left-hand side of the chart. It's been based on trying to build up a set of estimates based on cost charges, and we've taken a more acute eye to that recently, given the momentum towards increased price and cost transparency, towards the moves towards population health models and other reasons for us to make much more nuanced operational decisions. And we realized maybe we were wrong. Actually, historically, we've sort of overlooked a few things, and now this is what we're doing. We're taking a look at individual implants and the cost of those individual implants by physician. And here's what your data looks like. Now, I think the important thing is to have the discussion without blame. I mean, it is you want to talk as colleagues, sort of discovering insights together. You want to allow them to ask questions. You want to make sure that the relationship is two-way. You probably don't want to come in with too much of an agenda. You just want to say, hey, listen, we've taken a new critical eye to this and we've discovered some stuff. What do you think? What should we do? Let's work together to come up with a plan. Is this within a range of variation that we are comfortable with or not? Is this an opportunity that is worth going after or not? Is this an opportunity that we believe in or not? That I think engaging in that constructive communication, that dialogue is just, in our experience, so critical in many change efforts. And I'm sure that Sophan from the EMR side can attest to many change efforts that have been undertaken in hospitals historically have failed because effective leaders come in with data and answers and a preconceived idea of what they want to do and how they want to do it, and they really the long and short of it is you have to make physicians partners with you as you go through a journey, and in our experience that mindset's half the battle, and we've had some very good experiences with that approach.
The other issue too, Tim, on this example, like the example I gave earlier about Valley Hospital, is that if you started to, I gave a profitability overall, but for hip procedures. But if you start to break that down by surgeon, by physician, what happens is it becomes very difficult to see variability within cost of implants, because in this case they have one charge for hip implants themselves, and so it was works in surgery and works in the hospital field knows there's wide variations in how much implants cost depending on high demand versus low demand, right? And so in this case, we actually had to really do a bunch of detailed data work to figure out, what exactly was surgeon B doing versus surgeon A, and really see is the profitability between the two, because you can't see the profitability if you don't know if every single case has the same implant cost based on the cost charge ratio. It's really a fascinating thing that we had to really figure out there. Good question.
Okay, great, thank you. I want to again thank our presenters, Tim Darling, Ben Regal, and Sapin Anand for their excellent presentation, and for all of you who participated today. We look forward to having you join us again for future webinars. This will conclude today's program. Have a wonderful afternoon.